Lovely, thank you very much. So I'm Ellen Ewer, I'm a children's physio based at South West London. As Harriet said, I did the MSc in Advanced Paediatric Physio last year at UCL, and then I'm now continuing as an honorary research associate at UCL to continue the research that I started during my MSc. So I'd like to talk to you today about the development and the initial validation of the SPIDER, which is a multi-systemic symptom impact tool questionnaire for patients with hypermobility related disorders. And before I start, big thanks to Jameson and Barrett, my supervisors, and then the EDS Support UK, EDS Society, and Hypermobility Syndromes Association charities for supporting research. So just a little bit first about hypermobility. So essentially, people that are more flexible than the typical norm. So they can have increased passive and active range of movement in some or all of their joints. Some individuals might have no symptoms at all apart from being a little bit bendy, and others can have a really varied and complex symptom profile associated with their hypermobility. You can see on this diagram here, there's quite a spectrum of hypermobility related disorders that range in terms of symptoms associated with them, and also the severity of the symptoms that they can have. And it's still a little bit unclear how some of the pathophysiology of some of the phenotypes of hypermobility, but it is understood that it's a difference in the structure of the collagen that make up the tissues in the body. So the main symptoms that are reported by patients associated with hypermobility are some musculoskeletal, so neuromuscular symptoms like dislocations, subluxations, muscle spasms, changes in sensation, pain and fatigue, but it can also stretch outside of the musculoskeletal system, with some patients reporting symptoms related to their heart, their digestion, their bladder and their bowels, and also their mental health, particularly anxiety and depression. What we found in research, however, is that unless directly questioned on these symptoms, patients are not necessarily associating this with their hypermobility related disorder, and they're not necessarily being picked up through assessment. So with this in mind, a group of international hypermobility experts have created SPIDER, which is a 31-point questionnaire measured on a 6-point Likert scale that looks at these main 8 symptom domains. And once the child or the adolescent has finished the questionnaire, we can map it onto the SPIDER's web, which gives a really lovely pictorial representation of their symptom profile. And they often do quite vary, as you can see on the 2 different ones we've got here, and this will vary for each child. So the validation process is quite lengthy. We have to make sure that this tool that we've created does what we want it to do. The start of the creation was actually in 2016 with a team of international hypermobility experts. And then in 2020, they established content and space validity. And then at the end of 2020, another MSc student, Dora Tang, established convergent and known group validity of 2 of the domains, the pain and fatigue domains. And then for my MSc project, we validated the anxiety and depression domains. So the aim of the research as a whole is to assess the psychometric properties of the SPIDER. This particular project is looking at the anxiety and depression domains. And we did this through assessing the convergent validity, which essentially means that the outcome measure scores similarly to another already validated outcome measure to show us that the themes are quite similar. And then also the known group validity, which is the SPIDER's ability to differentiate between people with and without hypermobility. So in order to work out our convergent and known group validity, we had to find a potential comparator that would do the job. There isn't as such a gold standard outcome measure for assessing anxiety and depression in children, but the 3 most commonly used ones are the Hospital Anxiety and Depression Scale, the Revised Children Anxiety and Depression Scale, the ARCADS, and then the ARCADS 25, which is a shortened version of the ARCADS. So in order to work out which one is most appropriate, we looked at 20 research papers, and the test reliability, internal consistency, concurrent validity, and convergent validity of all of these 3 outcome measures. And in essence, the ARCADS and the ARCADS 25 scored most highly on all of the statistical analysis, and the HADS depression domain didn't score very highly on most of the research papers. So with all of that in mind, we decided to use the RCADS 25 because it was shown to be reliable and valid and retain the properties of the full RCADS, but whilst reducing the clinical burden on the child who was having to answer these questionnaires alongside the same questionnaires. So how did we gather this data? So we were granted the UCL ethics approval, and we used 3 charities to recruit our population. And these charities advertised the questionnaire through their social media channels and on their website. So it was a self-selection recruitment process. And we also encouraged snowball sampling to with both hypermobile and non-hypermobile adolescents to complete the data. We used RedCap to host our online survey, and we collected demographic data and also answers for the spider, anxiety and depression domains, and the RCADS 25 questions too. And once we collected the data, we analysed it using SPSS, and we looked at correlational analysis for our convergent validity, and we used the manual EU for our known validity. So a bit of a whistle-stop tour of the results. So we recruited, or we had 200 participants that filled out the full questionnaire. So after excluding ones that weren't appropriate, there were quite a few that were outside the age limits or didn't complete the full questionnaires. And we had 180 children and adolescents in our symptomatic hypermobile group, and then 20 in the non-hypermobile group. They were predominantly female, particularly in the hypermobile group, and also predominantly Caucasian and from the UK. So the results of the anxiety depression domain. So this is our convergent validity. So essentially this shows us that if the spider's anxiety result score increases, so does the RCADS in a similar vein, which shows us that we're measuring similar concepts. So the first graph here is our anxiety scores, which had a moderate correlation of 0.6, and it was statistically significant. And then we had a slightly higher correlation in the depression score of 0.79, and again this was statistically significant. So in essence, showing us that they melded well together and that the RCADS and the spider had similar outcomes. And then we looked at the known group validity, essentially seeing whether the spider can differentiate between those with and without hypermobility. So the blue bars here are children with hypermobility and the blue bars without. And this is looking at the impact of anxiety and depression on quality of life. So you can see there is quite a difference between the hypermobile group and the known group. And there was a statistically significant difference in the impact of anxiety and depression on these children in the hypermobile group. So what does this mean? So once this tool is fully validated, it gives us a novel approach to assessing the symptom profile of these adolescents, because as I said before, a lot of these symptoms go a little bit under the radar and aren't necessarily associated with their hypermobility and condition. And this helps us to streamline care, to find where these children are most affected and who they need to be sort of under the care of to make sure that they're managed appropriately. It's quick and easy to use, and it doesn't have a large clinical burden. We're hoping to develop an app at some point as well, so children and parents can use it at home or within a clinical setting, and it can be used by the entire multidisciplinary team. It's not just a physio app. We're hoping it's used by pediatricians and rheumatologists. So this is where the next part of the research comes in. We're currently validating 4 remaining domains. And we also would like to look at reliability, sensitivity, and specificity. And at the moment, we're using it as a screening tool rather than an outcome measure. But we would like to use it in the future as an outcome measure. But to do that, we need to establish the minimal clinically important differences, which in essence says that if there's an increase on the outcome measure, at what point is that significant change to the patient? So in conclusion, for the MSc study, there was acceptable convergent validity of both the anxiety and depression domains. So essentially it measures what we're hoping that it will measure, and acceptable known group validity that we can differentiate between those with and without hypermobility using the spider. So what's next for the spider? So we're currently in recruitment phase for remaining domains, which are the gastrointestinal, urogenital, cardiac dysautonomia, and neuromuscular. We're going to be hopefully finishing recruitment in June or July, and then we can start looking at data analysis. We're then hoping at some point to validate this tool with adults. At the moment, we're using adolescents between 13 and 18, but we would like to validate this with adults in the future. As I said before, we'd like to establish the NCID so we can use this as a tracking tool to see progress with certain treatments. And then it's something we'd like to publish these findings, whether we'll do them in small chunks or one project. Yeah, that is everything. I'd be happy to take any questions.